Much for the very nice introduction and the opportunity to talk about our experience with the MRI-only workflow at Karolinska University Hospital. This is my disclosure. Well, I particularly wanted to start with the acknowledgements, not only because probably I will run out of time, but I think I want to express how important it is, the fact to have a multidisciplinary team that actually drives this all the way through. Without them, it would not have been possible. But particularly to the Department of Radiotherapy, I think the whole department, I give a great thanks, because without them, of course, this kind of technology would never get to the actual patient as well. I would also have to say that we had the help of Philips all the way from the very start, so I'm very grateful for that. So how does the radiotherapy department at Karolinska look like? Well, we have 8 linear accelerators. We can treat with photon beams with up to 15 MBs. We have techniques anything from 3D conformal all the way to TBI. 2 of our linacs are actually equipped to deliver treatment with electrons. And supporting this linacs, we have 3 CTs and 2 MRs. We also do have a gamma knife. We have a brachytherapy department. And we are part of the national consortium that works together with a proton clinic called Scandion, which is located in Uppsala, about 80 kilometers north from Stockholm. We treat a wide range of diagnoses at Karolinska, but most prominently is breast and prostate cancer. And in the graph right there, you can see more or less the amount of patients that we are treating from, let's say, 2019 all the way to the first quartile of 2022. I would say that around per year, we would have around, let's say, 2,500 to 3,000 patients per year. So this is the size of our department. And now I would like to focus on the MRI only. Why an MRI only? What does it mean? Well, I will start with how the routine workflow is, and that is, as you all know, we take an MR, and then we also take a CT. And these 2 images will get registered. They will be sent to delineation. The delineation, we use the MR. And the dose calculation, we have to use a CT. And when everything is done, we are ready to irradiate the patient. Well, what does an MRI only intend? Well, we would like to keep the superior soft tissue contrast of the MR. So we would like to keep that. But we would like to eliminate, actually, the errors that are come from the registration process themselves. So in the end, what we are seeking is to take away the CT altogether. And this we can only do it if we actually have some sort of synthetic CT, a CT-like image, right, in which we can do our dose calculations. So Philips actually has come up with several products. Their product is called MRCAT. It's this so-called synthetic CT. And today I will be focusing on the MRCAT pelvis and the MRCAT brain. These 2, we will go into a deep explanation about how we did this clinical implementation. And well, the benefits is obviously a lower cost, it's more affordable, and it just simply simplifies your workflow. So let's dive into how the MRCAT pelvis is done. If we start with the imaging, there is an M-Dixon sequence, and out of that you will get 3 different images, weighted images, 1 water, 1 fat, and 1 in-phase. And then after that comes the segmentation process. It's a model-based segmentation of bones and then the body outline. And then you also have the soft tissue classification that happens. And then after that you have the density assignment. It's a continuous Hounsfield units based on fat water content and the bone segmentation. And this is really cool because everything is actually running parallel to the image acquisition, so there's no time added to the session, to the MR session. The MRCAT brain, on the other hand, is a little bit different. There we have a training data set. So we had the MRCAT sources from a 1.5 and a 3 Tesla, and you have the CTs there. All that is fed into the algorithm. And that is the one that we use in the end to come up with the MRCAT of the patient that's being imaged. It is a fast computation of the attenuation maps. That is done actually at the MR console. And using dedicated high-performance GPUs. And it's also continuous Hounsfield units that go into the MRCATs. So now let's dive into the MRI-only clinical implementation. We cannot start this talk without talking a little bit about quality assurance, and this is a program that we have at Karolinska. we basically follow Philips' recommendations for this. And as you can see, we have weekly tests and the daily test of the laser beam. Particularly, I like to point out the PIQT that's done weekly, and we also decided to do it the same day that an MRI-only patient is coming in. And this is all automatic. So basically, I think the allotted time at Monday morning, I would say it's about 1 hour probably. And we have these phantoms as you see here. What about the MR sequences? Well, we have for pelvis, we take a T2 weighted, and that's used entirely for target delineation. And then we have, of course, the MRCAT source for the generation of the synthetic CT. For the brain, however, we added 2 more sequences, one T1 and one FLAIR. All of those are actually being studied and to see which one would be the best, I guess, for target delineation in the end. So, but what I wanted to point out here is the total time of the scan. So for pelvis is about 8 minutes. I believe that the allocated time slot for the patient would be probably around 20 minutes to 30 minutes, 20 minutes most likely. And for the brain, of course, it's a little bit longer because not only we have the 2 extra sequences, but the patients have their mask fixation, so that takes a little bit longer in the preparation. So I think there are about 40 minutes to 1 hour probably allocation there. Okay, we said from commissioning to implementation, I would like to, I think of it more of as a process, the clinical implementation process, and that I divided into 3 phases. Go from commissioning, validation to actually the go live. So in the commissioning, what we did was to take, we treat the patients in the normal workflow, that means a CT MR based, and we have the MRCAT that's being taken on behind. There we do all of our analysis is done retrospectively. We take a look into image quality, we take a look into contouring capabilities and the dose performance in that phase. Then if we're happy with that, we go into the validation where we now flip the coin, and now we have the MRI-only patient being treated in an MRI-only workflow. However, we still have the CT on the background, both in case we need it, in case something might go wrong or whatever, so we still have the CT there, and also for retrospective analysis. At this point, it's very important to, you have to adjust your guidelines, right? I mean, you're coming from one type of workflow to a different one, so adjusting guidelines is important. Training is absolutely important. I think training is also quite good, your staff. It's also good practice to have an end-to-end test, that means a dummy run. And as a retrospective analysis, we took a look again into the dose planning performance, and at this point we do the patient positioning performance. And then if we're all happy with that, then we go live, basically. And that's when we are all feeling confident that we can drop the CT altogether. Again, there's some training and adjusting if needed, and of course there's some monitoring process going on in the background. So let's jump into the commissioning. For pelvis, we started in fall 2020, and it took about 4 months in total. For the brain, we started actually last year, and it's a little bit longer time there. Some general information about the patient group, for example. For pelvis, it was decided that we would start with rectal cancer patients. These are patients that are getting RT before surgery. The prescribed dose is 5 grays in 5 fractions. We used the calibration curves, the Eclipse default calibration curve. This was a clinical decision. The technique that we used for these patients, radiation for these patients, is BMAT, 2 arcs and a 6MB. The fixation is quite simple. It's just a knee support, and we started with we start with the 3 markers, tattoos, basically, on the patient. And at the time of the first fraction, or at the time of the treatment itself, we have a CBCT at each of the fractions, and we have a bony match. For the brain, on the other hand, we started with glioblastoma. That's a group of patients that we looked into. These are the different doses that we prescribe. And basically, the rest is the same, except for the short mask, which I already mentioned. Of course, as I said before, we looked into, let me just go back very quickly. The first thing that we looked into was image quality. And so I will present to you the actual results that we have for the image quality of the pelvis. There are 3 things that we looked into, 3 aspects. One was the body contour, the other one is bone tissue, and the last one was the markers. Unfortunately, I don't have that much time to explain each and every single one, so if you want to talk about this, of course, I'm open for questions afterwards. But the one that I would like to point out here is a colostomy bag. Remember that we have rectal cancer patients coming in, so most of them actually do have this bag. And we observed some issues with it. In this case, we had 10 patients in this commissioning phase. 2 of these patients actually could not generate the synthetic CT because of this. But the image that I show here is actually telling you that sometimes, yes, this patient, for example, had a colostomy bag, probably also something else, because we see this huge artifact, as you see there. But it was decided to actually go forward with this image because what you can do is just simply fill in the missing gap and just simply override the density. Now, this has to be taken, you have to discuss it with your oncologist, with your radio-oncologist, and we were confident here in this case that it wasn't a problem. Why? Because the area of irradiation was actually far away from this, so we knew that the dose difference, the dose distribution would not be affected by this. So by this, we're saying that, there are images, you have to just simply take a clinical decision if you want to go ahead with this type of image or not. What about for the brain? Well, we looked as well in the same aspects. And again, I'm not going to go into detail of all of this, but the one that I would like to point out here is the tabletop. Unfortunately, you cannot see the tabletop on the synthetic CT. So we need to come up with a solution for that. And for that, we decided to actually take an extended field of view T1 weighted sequence. And in the first slide, I guess you can have, here. I have here the registered image of the CT and the extra slices that we are taking, so it's a little bit more down. But if you see on the transversal view, we have placed actually 2 markers on top of the table in the MR, and so we go and search for them, and then we place on Eclipse, which is we work with Eclipse. We put these markers exactly in these positions, and so when we go into our dose planning, we know exactly where to place this support couch. So that is our solution to this problem in the end. Well, again, you can talk to me about any of the other ones later on. What about contouring? Particularly for the brain, this was, I would like to point this out because it was in the end a whole master thesis work from a student that we had. He actually analyzed 100 subjects, so we did have an MRCAT behind for these 100 patients. And what was the interesting part here is that we wanted to compare the CTV that was delineated in the CT-MR-based workflow, and how would that CTV, if it would be contoured only on an MRI only, that means that we're not looking at the CT at all, how do they compare? And well, the results were pretty promising, actually. So as you can see by the dye similarity, it's about 0.94. So that means that both workflows for just the contouring, the guidelines for just the contouring are actually equal, so that we were very happy about. They are different workflows, so in the end it did result in new instructions for both the organs at risk and the CTV. It was just some technical differences. Again, I can talk about it if you want later on. But I do have a point of caution here, as you can see. These patients, most of these patients were actually operated. And during the operation, well, you have sometimes metal artifacts in there. And that is a void in signal in the MR. And what happens is that that void is filled, it's translated, so to speak, as bone. So that means that it's an enlargement of the bone, basically, what you're seeing. So we had a serious round of discussions as to how to handle this when it comes down to CTB delineation. So you have to go to your oncologist and have to come up with a strategy on how to do this, because yes, there might be, because it's enlarged, then there is a few millimeters that you might, we're talking about 1 millimeter, 2 millimeters that you might be missing while you're contouring when you're so close to this area. Finally, for the distribution comparison, here I present our results from pelvis and for the brain. What we did is that we had the optimized plan on the CT that we made a copy directly on the synthetic CT and just simply compared the DVH, some DVH points in those. And we were very happy because the CTV and the PTV means for both the pelvis and the brain are under 1% difference. And however, the organs at risk, there we see a little bit of a difference. For example, for the chiasma, we see up to 4.4. But I do want to point out that the reason for this is because there was a difference in the voxel size between the CT and the synthetic CT. So observe, if you want to do these kinds of comparisons, it is very important that the voxel size should be the same. And of course, there's also a residual problem here of the registration itself. So part of the difference that we're seeing here is due to that. And not only this, in the chiasma as well, you can see that it's 0.4 cc's. So we're talking a very, very small volume. And on top of that, we're talking about dose to the 2% of that volume. So yes, we're talking about very, very small volumes. So yes, in some cases, we managed to see that there was this kind of discrepancy. But so this was not to discourage us at all. We were actually happy with these results. And the decision was taken to actually go forward into the validation phase. So the validation phase for the pelvis, it started sometime in the winter of 2020, ended up in the first quartile of 2021. There we had 2 months of preparation. I will come into talk about that, and 4 months of including patients during this phase. And for the brain, I'm very happy to say that we are it's ongoing right now. So we are gathering the information still at that point. So validation phase, what do I mean by preparation time? Well, I talked about the guidelines, and these are key important things that you need to look into. It all starts with gathering within your group. You have to discuss. A risk analysis it's very good because you can go through all the problems. It makes you think about what kind of problems you will see, not with the technology-wise, but what actual problems can come up in the application, in the workflow, let's say. So once you have that, you sit down, you write your protocols, you write your guidelines, then you go on to train your different groups. And the test comes in. I think it was very good for us to actually send an end-to-end test, not only to test obviously the chain, so that in each task everybody knew what they were doing and if the actual guidelines were being followed or understood. And so after this end-to-end test, we sat down, we evaluated. Was it okay? Did we need to do some adjustments to the guidelines? So that's the point where you actually adjust the guidelines if needed. And then if you all feel comfortable, then it's about time to start your patients, including your patients. Remember that during this validation phase now, we are working with an MRI-only workflow. So we do have the CT, but we basically do not look at the CT during the whole time. So what were the results of that during the validation phase? So I'm talking obviously only about pelvis because this is what we have information from. So along these months, we had 42 patients were planned to go through an MRI only. We had 30 of them actually completed successfully this MRI only workflow. But however, I need to point out that it wasn't because the MRCAT, this 29% wasn't because of the MRCAT wasn't generated. It was just simply things that happened along the way. So here's a list of things that actually happened along the way and why we had these dropouts. I mean, medical decision not to treat, we can't really do anything about that, right? But all in all, it was actually 6 patients that were dropped out because the MRCAT was not generated, and this was also due to the colostomy bag. So in the end, we had to figure out what to do in order to reduce this amount of patients that were being dropped out. And we saw that actually by asking the patients to come in with an empty bag, for example, or to change the bag just before the MR simulation is being done, that actually was much better in that sense. So this was a lesson learned, basically, from that part. About patient positioning for this validation phase, you can see here that we have a CBCT matched with the CT and the CBCT matched with the synthetic CT for both translation and rotation. And we basically see no difference, and we had no report of any difficulties actually in making the CBCT matches. So we are confident that the synthetic CT is doing as well as the CT that we had before. So we were very happy with all of that. So we decided to actually go clinical, go live in May 2021 for pelvis. That means that we already entirely dropped the CT altogether. And for the brain, if everything goes well, it's planned somewhere between the summer and the fall of 2022. So hopefully you will get some more news in the next Estro about how we did. And then, in the clinical phase? Basically, as I said before, you have to evaluate what happened during the validation phase, right? So that you need to still do some adjustments to the guidelines. And here the training actually happens to the whole personnel in the end, because again, it's the whole radiotherapy department that will be handling these patients. And once we were happy with that, well, it's just to push play and then start actually treating our patients with an MRI-only workflow. And we did some monitoring, but nothing was of note. So I'm very happy to say that today, actually, well, in 2021, we treated about 55 patients already, and up to, I think it was a week ago, there was 18 patients that have been also treated with an MRI only. We have a stable routine in place in case an acute CT is actually needed. I already mentioned there was no report of difficulty in the CBCT matching. But also very interesting that we decided to start with is the use of surface positioning for these patients. So we no longer do tattoos for this particular group of patients. Actually, we don't do tattoos for any of our pelvis patients, GIN or prostate or any of them. So we place them all with the surface positioning scanning. And we've had great results with it. So that's one less thing that the MR personnel actually doesn't have to do, which is the tattooing, and it's very good for the patient themselves as well. So lastly, for future work, well, I've been saying that brain, it's there. We're looking into glioblastoma. We still need to evaluate the end-to-end test. And then we are also looking into prostate, specifically gold marker evaluation. That is still on the planning part, but hopefully we will be able to kickstart that project now on 2022. And then the head and neck, it received already the CE mark in 2021, so I know that it's available. I guess if you have more questions about that, I can direct them to the Philips people. And we hope to actually get this product up and running. The commissioning project would start sometime during the next year. So I would like to just simply finalize with these take-home messages. I think if you boil everything down to how can we make this successful implementation, I think one thing is the anchoring process in the management. It's very important that you have also a project organization. You have a good project, a good, well thought through project, and then you have to go talk to the management and say, like, yeah, please. I mean, this is really needed in the clinic. So by that you have stable ground to work with. One thing that was visible through this entire process is that establishing communication chains are vital. You have to make sure that everybody along the chain knows what they're doing and how to react in case, well, we need an acute CT. Who do we talk to? How do we make this happen so that the patient is actually not coming back for a CT, for example? So that is very, very important. And the training of the staff, of course. Everybody needs to be in the same page. So with this, I would like to thank you, and thank you for your attention. And questions, I guess, it will be answered afterwards.
Thank you, Fernanda.